we'll end now with three, we've talked a lot about metastatic disease. We'll end really, I think, with some comments on some, I think, very important abstracts that are being presented at this year's ASCO meeting in terms of adjuvant therapy for breast cancer. And Kim, you hinted at the first one of those, which is the MA17R study. Could you summarize that for us?
Yeah, so we've all been waiting for the results of MA17R for quite a long time. I think, if I remember correctly, we had the results of MA17 in 2003.
Two. It was published in 2003.
2003, so this is 13 years in the making. That's a dedicated study
It's a
team.
teenager.
Yeah.
And yeah, I wasn't even born when the study was reported.
True.
But the bottom line
Absolutely
is
true.
that it took postmenopausal women who had early stage breast cancer and had completed 5 years of tamoxifen, 5 years of letrozole, and then I think it was roughly about 800 patients that then got randomized. 1,000.
Yeah,
1918.
Oh, 1918, really? Okay.
That got randomized after 10 years to either continuing the letrozole or continuing on placebo, blinded study. And basically what the study demonstrated was roughly about a 2% absolute difference in disease-free survival in favor of continuing the letrozole past the 10th year. So, and there's another presentation at this meeting showing that there's no impact of continuing it on quality of life, as best as they could, ascertain by quality of life. So I think, I was a big early adapter to 10 years of endocrine therapy. I've hinted at it throughout our discussion this morning, and at least for my patients who are doing well, who have adequate bone health, whether they're on a bone health agent or not, I will discuss continuing it past the 10th year.
And I think the data will be coming out later today.
Yeah.
But what I've seen just written in summary so far was a 4% difference at the five-year mark, 95% with letrozole.
Which is the absolute 15-year mark. So
yeah,
it's
the
the 5-year mark of the trial.
Yes,
yeah.
yes, and 91% with placebo in terms of the patients
So 4%,
that remain.
sorry.
Yeah, 4% remain NED, so a hazard of 0.66, a 34% reduction in recurrence.
But is that low? But the key is, when you say recurrence, it's in DFS. And remember, probably I'm guessing, at least looking at the data that I've seen so far, that the DFS is mostly new contralateral breast cancer.
It does, but it's
and
small
not
percent.
really metastatic disease.
No, it's 0.2% with letrozole, 0.4% with placebo for
Okay.
contralateral. So there's a benefit, but it's not accounting for this 4% difference.
But I think it'll be really interesting
to see
now,
it, yeah.
from a quality of life. These were women who were prepared to be randomized after 10 years of endocrine therapy to go for an additional 5 years of treatment or not. So I think, as there is a selection process as to who those women were, we've already said, okay, you know what, it hasn't been that bad. I can go another 5 years. So I'm not sure how much to put the emphasis on the quality of life. It'll be really interesting how they report it. But yeah, to me, the most clinically impactful is not this patient group is 5 years of tamoxifen, 5 years of letrozole, another 5 years of this treatment. The question from a clinical context is what to do for those patients who have had 5 years of NAI who come to us and have not had prior tamoxifen. This shows that there is ongoing benefit of aromatase inhibitor beyond 5 years.
It predicts B42, which is going to probably be announced at San Antonio.
That's right. So I think this sort of justifies the rationale of continued AI suppression.
I think I'll go home from the meeting, whereas before I would say to patients, there's no data that you should have to take this drug past 10 years, and say now there's fairly good data that continuing it past the 10th year might offer you an additional benefit.
Yeah, I just hope we don't see a 15 versus 20-year trial.
We may.
I want to bring up a point that is perhaps philosophical and that I've reflected upon, that I think as a community, I think we should do better than this. I mean, I'm happy and I celebrate the people that benefit from this trial. I'm happy that the quality of life was not affected, although there was a clear selection process going on for a decade. But I think that I would hope that as we identify targeted therapies that trump that late recurrence, we should be cutting back on the length of therapy. I mean, so again, that's just
selection. I mean, we can talk again. We probably, in the interest of time tonight, we don't have the time to talk about even selecting people for therapy.
Yeah.
Maybe there are luminal A patients who don't need anything.
Correct.
Or minimal therapy, and 3-5 years, that's it. But one last thing.